good evening, good afternoon. Hope all are fine. Welcome back to the channel. I am Linda Osunga, an orthopedic trauma technologist. I would like to do a continuation of my previous video that I was talking about first aid. And today I would like us to talk about pre, in, and post management of patients that have involved in an accident. Just an oversight, it's in the public domain. WHO estimate 1.3 million accidents cases, and in this case some of them are mass accidents. So for the case of for this context, let's discuss about polytrauma. Polytrauma is an injury that involves several body systems of the body. So for this context to happen, there are categories of patients that we are supposed to categorize in order to triage these patients so that it make it easier to manage. One of the categories would be severity to the severity of anatomical trauma. We also have level of physiological response. We also have demographic and comorbidities. We also have autoimmune and genetic predisposition. Out of these, we zero in to classify patients according to scores so that we get to know which patients that can benefit from where they've landed in the hospital, those ones that will require referrals, appropriate referrals, those ones that will require, and we can also get to know the prognosis of these patients. So there are scores that were developed to handle these cases. One of the score is called abbreviated injury score. The second one is revised trauma score. There is chronic physiological and acute health evaluation. There is Kampala trauma score. There is trauma injury severity score. For AIS, abbreviated injury score, it is a score that ranges from 1 to 6, with 1 being normal and 6 being severe. And it involves 6 body parts, 6 body systems of the body, that is face, abdomen, head, thorax, pelvic, and external structures. So according to this score, there is another one that was developed called Injury Severity Score, ISS. ISS is it is a score that sums 3 squares of IAS. IAS is abbreviated injury score, and it sums it to be 75, meaning when the highest in IAS is 6, that makes it 75 automatically. But this 75 only for 3 body parts that have been affected. After realizing that this only classifies body parts that have been injured, it cannot classify a patient. It cannot score a patient that has an injury, severe injury in a singular body part. It was abolished, and a new ISS was invented that sums 3 body parts, irrespective, 3 squares, injury of 3 severity, injury of 3 severity. It is a sum of square of ISS with 3 severely injured body parts, irrespective of the body system. And then we go to revised trauma score. Revised trauma score is a score that it is a score that involves parameters of physiological stature. So it involves respiratory rate, it involves systolic blood pressure, it involves glycoscoma scale. This score ranges from 0 to 4, with the 0 being severe and 4 being normal physiology. So if a calculation is done and the patient has a score less than 11, that patient requires immediate transfer to appropriate trauma unit. We also have acute physiological and chronic health evaluation. I would shorten it as Apache. Age, it calculates its score using age. It calculates its score using genetic factors, commodities, previous history of surgery, or ongoing if the patient is currently in the intensive care unit. And basically this score is used to see the prognosis of the patient while being treated. And then we have trauma injury severity score. This is equally sophisticated, and it involves revised trauma score. It also involves reverse trauma score. It also involves AIS. So it sums it up with a coefficient of MTOS. MTOS is a retrospective descriptive study of severity. Trauma injury score is a sophisticated injury score that sums KTS and AIS with a coefficient of MTOS. MTOS is a retrospective descriptive study that studies severity of injury and its outcome. Thus, this is an indicator of survival of an injury. And then there is Kampala trauma score. Kampala trauma score is generally used for mortality score in areas where resources are limited. Basically, it's mostly used in Africa, but it uses the mentioned above kind of scoring. So after scoring these patients, we can now categorize them according to we can now trial them according to their injuries and be able to help them to reduce mortality. According to this, there is initial assessment. Initial assessment, we employ AMPLE. AMPLE is a short history taking that involves allergies. It involves medication that the patient has taken. It involves past medical history. If it's for a lady, if there is pregnancy that was involved or that is involved, the last time meal that was taken, and then events leading to the event that led them to the hospital. So in the treatment of polytrauma cases, we employ ABC. There is in-treatment, pre-treatment, and deaths. So for pre-treatment, these are treatments that we offer to the patient before they reach the hospital, and they include securing the airway, in cases of shock, admission of fluids to be started immediately to reduce mortality. Pre-hospital, there is A, B, C, D, E, and I'll discuss it later. And then we have deaths. Deaths can be in three categories. There is immediate death, there is early death, and then there is later death. Immediate death are those ones that come in the hospital with a disrupted CNS and cardio and circulatory. It's completely severe that we cannot do much about it. These are injuries that can give a room. When they are handled appropriately with appropriate time, they can gradually improve. The time is usually called a golden hour. And if it is not treated that time, the patient deteriorates drastically, leading to death. Then we have late death. This is due to sepsis and multiple system failure. From the deaths, now we can do the ABCDE. ABCDE involves airway in the management of polytrauma. Airway, we check for most polytrauma patients. We normally treat them for cervical injuries. So definitely we'll have to immobilize the cervical spine. And we'll have to check for foreign bodies if there is vomitus. We can also be listening to the breathing, the abnormal breathing of the chest. If there is striding or gargling, the striding like the patient is, we can also diagnose this clinically. We see that treatment of airway, there are conditions that when they are there, technically automatically this patient has to be intubated. One of them is when the glycoscoma scale is less than 8, when there is head injury, when the patient is unconscious, when the cervical spine is injured, when there is obstructive, when the airway is obstructive, when there is serious maxillofacial injury, definitely we'll have to intubate. There are four major breathing structures that can be affected. That is intense tension pneumothorax, frail chest with pulmonary contusion, we have massive pneumothorax, and then we have open pneumothorax. In tension pneumothorax, we find that it is characterized by artificial valve that gets the air inside the pleural cavity with no way to come out. So this results into lung collapse and also results into mediastinal displacement into the hemothorax. This can result to cardiogenic shock. This pneumothorax can be clinically diagnosed through tracheal deviation. We have distended neck veins. There is hyperpercussion on the affected side. When you percuss the side that has been affected, there is hyperpercussion on the affected side. Sometimes there is even shock. Sometimes later feature can be cyanosis. So treatment is generally emergency decompression by inserting a tube on the second intercostal space between mid-clavicular bone. So it is the tube enters in the second intercostal space between mid-clavicular line. There is also chest drain that can also help with that. And then we have frail chest. Frail chest is when there are 2 or more rib fractures that has occurred in 2 or more places. This results into injury of the lung parenchyma cells, and also can result into lung parenchyma cells also results into paradoxical movement that suggests altering of ventilation. This can be treated through analgesia, through epidural analgesia, and there is also continuous fluid admission, and there is also appropriate intubation. Massive pneumothorax is when there is excessive volume of blood within the pleural cavity that affect respiratory function. This results into shock, hemorrhagic shock. So this shock can be treated by tube thoracostomy, and there is concurrent restoration of fluid volume. Tube thoracostomy, open pneumothorax, this is when the chest has wounds that is 2/3 of that of the trachea. This means that the air enters through the structures with no way of coming out. It's slightly the same as the tension pneumothorax. The difference is that there is open wound. So the treatment is occlusive dressing on the injured on the wounds, and also timely insertion of chest tube to drain. And then we have circulation. Circulation, when it is altered, generally there is a shock. Shock is when there is obstruction. The oxygen is not reaching the vital body organs. There are 4 types of shock. We have obstructive shock. We have hypovolemic shock. We have distributive shock. We also have cardiogenic shock. Hypovolemic shock is a shock that results when there is fluid loss. Hypovolemic shock occurs when there is fluid loss, e.g. blood. Yes, when there is a lot of blood, a patient can go into shock. Obstructive shock is when there is less blood flow to the major body organs. And then cardiogenic shock is when the heart malfunctions due to, and then there is obstructive blood flow, obstructive shock, emboli. Emboli can also obstruct a flow. Yes, and then generally fluids, we can give 1 to 2 liters of fluid to an adult with warm crystalloid and 20 milligram per kg in children. And this one can be done as you monitor the vitals. If the vitals are not, if the patient is not responding, then we need to check for bleeders. Bleeders can be checked for in thoracic cavities. We can check them from pelvic cavities. We can check them on long bones. We can also check them on the abdomen. Those are the major areas that can have bleeders that are not really external, they are internal. Yes, so we realize that when we are administering fluid, sometimes there is also blood that we also administer, but it's suggested that also helps this. It reduces, when this is done, it helps in reduction of shock and reduces mortality. So with disability, we can assess the neurological status of the patient. It can also give a heads up to the clinician to know that how well the patient airway to circulation, how well are their parameters, how well is the glycoscoma scale stabilizing, is it deteriorating or increasing. Is also exposure. In exposure, because this is a patient that is losing a lot of blood, we ought to be keen so that we don't get this patient to lose a lot of heat, resulting to hypothermia. Yes, so if you have any question, you can type down below, or you can inbox me, or you can suggest a topic if you want us to discuss, or maybe something that you've not understood that you need to be explained better. I'm glad to do that. Thank you. Keep subscribing.